Hello, this is Stephen Holloway. We're going to be talking about cardiac dysrhythmias. You've already had a chance to review the basics and reading a rhythm strip. Looked at basically what a P wave, QRS, T wave looks like. Look at the length of the P, the PR intervals, distance, length of a QRS, the ways to check rate, rhythm. All of those are part of one that has been published already in our Integrity series. So what we're going to do today is I'm just going to go through some basic rhythms for you, everything from normal all the way up to the lethal or deadly dysrhythmias. Now, toward the end, I will be talking about AV or AV blocks, okay? The only AV block that is typically tested in N202 on a unit test will be the SA block, or excuse me, the first degree AV block. That does not mean that on HESI exams you won't see second and third degree blocks. So I am going to mention those, but do know from my unit test, I will not be putting second and third degree blocks on the unit test. As you approach the rhythm strips, I want you to approach these rhythm strips with one thing in mind. Do not treat the strip. Again, do not treat the strip. Treat your patient. I don't care what you see going across the monitor. Always assess your patient. Always assess your patient. It's imperative that if I ask you a question about a rhythm strip, you do not have an assessment on that patient, then you're to assess your patient. Okay, same thing when you go to boards. If they don't give you an assessment, then look at assessing that patient as part of your process for these for what's going on. Let's look at what normal is. What is considered normal? Normal is considered a normal sinus rhythm. A normal sinus rhythm has a rate of 60 to 100 beats per minute. And when we talk about beats per minute, that's basically how many atrial and how many ventricular beats there are per minute. When we look at this strip, each strip that I will give you will be 6 seconds in nature. You should have markings. It's here, there's one here, and one here that indicates a 6-second strip. So from here to here is 6 seconds. What I want you to do is count the number of QRSs within that 6-second strip. So if we count if we count 1, 2, 3, 4, I'm learning to use a new tool. I apologize. 5. It's not working. Okay, we'll get there. 5, 6, 7, 8. In other words, basically 1, 2, 3, 4, 5, 6, 7, 8. We have 8 in there, so we've got a rate of 80 on this strip. Notice that this one falls outside those areas, so it's not counted. Again, when we're looking at our rhythms, go back to your 5-step. Look at your rate, look at your ventricular rate, then look at your atrial rate. The atrial rate's calculated by counting the number of P waves in that 6-second strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9. Well, your rate is 90 in 6 seconds, but look how close it is to this. So we know that this is basically 1-to-1. You've got a P wave for each QRS. You have a QRS for each P wave. And checking your rhythm is very difficult. There's no way I can show you on the computer. But basically what you would do is you would take a piece of paper, lay down the paper, and mark on that paper here and here. Then you would slide that paper to see if these are regular. If the marks on your paper match up with each one of these, then your rhythm is regular. Don't try to eyeball it. On your computer screen, you can do that. Be careful, though, when you put your pencil up there. Do not puncture the screen of the computer. PR intervals should be between 0.12 and 0.20 seconds. 0.12 seconds is basically 3 of the small blocks. 0.20 seconds is 5 of the small blocks or 1 of the large boxes. When we look at basically a large box, excuse me, let me go down here. I'm trying to, again, I apologize. I'm trying to learn how to use some new tools with this. And lost my cursor. If we look at our block here, we can see this large block contains 5 of the smaller blocks. Okay. Each of these small blocks is 0.004 seconds. The large block is 0.20 seconds. The PR interval, which is highlighted here in yellow, begins at the beginning of the P wave and ends at the beginning of the QRS. So what you need to do is count the number of small blocks in there, multiply it by 0.04, and that'll give you your PR interval. In this particular one, it looks like your PR interval is about 0.18 seconds. In other words, 4.5 small blocks. It's going to be important. Now, I promise you on your test, these will look a little bit brighter, so you should be able to see the blocks much easier with that. If for some reason they are not marked at the top of this screen, you would count basically these blocks. So it'd be 1, 2, and you would count basically up to the last one, and this would be 30. So there's 30 blocks in a 6-second strip. So if you don't have markings, pick a spot, line it, then count down to the next one, and then that, once it's to 30 blocks, that is a 6-second strip. As you're looking at your strip, again, remember to look at your P wave. It should be upright and positive, upright and positive. All strips will be in lead 2. Lead 2. So you should see those upright and positive. So you should be looking at the P, the PR interval, the QRS. Look at the T wave. Is it upright, which it should be in lead 2? Is it flat? Is it inverted, which could indicate ischemia? So those are the things you're going to be looking for. So this is a normal sinus rhythm because the QR complex is less than 0.12 seconds. The PR is less than 0.20. The rate is between 60 and 100, and it's regular. It's a normal sinus rhythm. As we look at this next strip, again, make sure you understand what to do. Now, you would count basically 30 blocks, and basically 30 blocks is from here, I believe, until here. I haven't counted them. But basically 1, 2, 3, 4, 5, 6, 7, 8. Our rate is 80 for the QRSs. Count 1, 2, 3, 4, 5, 6, 7, 8 P waves in that time frame. So our rate's 80-80. There's a P wave for each QRS, a QRS for each P wave as we look at it. Now, the rhythm is regular. You would have to, again, march it out to see if the rhythm is regular, and it appears the rhythm is very regular on these. Again, you're going to look at your QRS complex, at your ST segment, your PR. Your PR is going to go from the beginning of the QRS to the beginning of the P wave. And that sometimes is very difficult to see. And you can see basically on these where it is. And it makes it easy here to highlight that PR interval is not quite, it's about 4 blocks, which is about 0.16 seconds. Could be a little bit more on other ones. Interpretation here says 0.18, so that's 1.5 blocks. Again, now look at your QRS. Your QRS basically is kind of wide. If we go from here to here, it should be 0.12, which is 3 blocks. This one's a little bit wider than 3 blocks. You can really see it on this one when you see where it ends here and goes back to here. There's 1, 2, 3 blocks. It's right in that borderline area. But it's kind of wider than a normal QRS. The T segment, ST segment is depressed, which indicates ischemia. I wouldn't call this a normal sinus. I'd call it a sinus because of the changes in the QRS complexes. This is really a sinus rhythm with a bundle branch block. I do not expect you at your level to be able to tell me that's a bundle branch block. Just know that that's not a normal sinus rhythm, but it is still a sinus rhythm. It's a sinus rhythm because the P waves are upright, they're less than 0.20 seconds, and they're in front of each QRS complex, and they're consistent. Other strips that you're going to see, sinus bradycardia, you already know that any heart rate less than 60 is considered bradycardic. Any heart rate greater than 100 is tachycardic. When we look at a sinus bradycardia, basically it's a sinus rhythm. On this one, let's say sinus because there's a P wave in front of each QRS and the P wave is upright. Sinus means it's coming from the SA node. So electrical activity is being initiated in the SA node. So it goes through the SA node, and then goes through the AV node, and then gets down into the bundle of His and the Purkinje fibers. So when we look at this patient, we've got our markings. So we know from here to here is 6 seconds. So from here to here is 6 seconds. Then we count 1, 2, 3, 4, 5. Our heart rate is 50. Now again, I want you calculating heart rate by counting the number of QRSs in a 6-second strip. What that means for you is your rates will always be in multiples of 10. There's other ways to calculate rate, but at this point in time, all I want you to do is using the number of QRS complexes in a 6-second strip. If we checked our rhythm, we marched it out, our rhythm is regular. We looked at our P waves, they're present, they're upright. There's a P wave for each QRS, a QRS for each P wave. If we looked at our PR interval is going to be about 4 blocks, maybe 4.5 blocks, so 0.16 to 0.18 seconds. Our QRS is a little bit narrow. It's 1 block. It's about 0.4 seconds. That's okay. And as we look at this, we kind of see that this is a slow rate. Now, what can cause sinus bradycardia? There are a lot of things that can lead to bradycardia. Okay, sinus just means that the sinus rhythm is beating slowly. An athlete that's well trained will have a bradycardic rhythm because they don't need as much rate to get their heart, get the cardiac output. Vagal stimulation can cause sinus bradycardia. Vagal stimulation can be things such as bearing too hard in a bowel movement, vomiting. You do actually stimulate the vagal nerve if you're in the ICU and suctioning a patient. Prolonged suctioning can cause bradycardia, not only from that, but from hypoxia as well. Increased intracranial pressure can cause sinus bradycardia, or can cause bradycardia. Medications, especially beta blockers, digoxin, calcium channel blockers, all can cause bradycardic rhythms. An inferior MI can cause that. Hyperkalemia, hypothyroidism, all may cause bradycardia. Patients may be totally asymptomatic with a bradycardia. If the rate starts getting down below 40, in most patients, though, they are probably going to be a little symptomatic. They may complain of some lightheadedness. They may have some syncope. If coronary artery disease is present at that rate, they may have chest pain because you're not getting enough blood flow to the coronary arteries. If it's asymptomatic, you don't do anything about it. If the patient is having problems, you try to see what the underlying cause is. If it's medications, you're going to hold the medications. If the patient is symptomatic, then we need to get the heart rate up. The drug of choice for increasing the heart rate is atropine sulfate. You'll give 0.5 milligrams IV every 3 to 5 minutes to maintain the heart rate. You can give up to 3 milligrams of atropine. If the atropine is ineffective, you can start a dopamine drip at 2 to 10 micrograms per minute, or epinephrine at 2 to 10 micrograms per minute. If those are not available, transcutaneous pacing is the first line, transvenous pacing until the situation is stabilized and we get them in for permanent pacemaking. So whether bradycardia is caused by whether it's a sinus bradycardia or bradycardia caused from junctional type issues, but a bradycardia has to be treated, and typically those are your drugs. Atropine, dopamine, epinephrine, and pacing are the treatments for bradycardia. Sinus, just another one you can look at. If you look at we have them up here. Basically, they're every second on this strip. So there's 3, 4, 5. 1, 2, 3, 4, 5, a 6-second strip. So 1, 2, 3, 4, 5. This patient's running a rate of 50. Probably closer to the 40s than the 50s if you actually looked at it. I will tell you another way to count it is basically it's called triplets. It's 300, 150, 100, 75, 60, 50. So this rate's probably about 48 beats per minute. Don't worry about that. 50 is what you're going to be looking at. So this patient may or may not be symptomatic when you look at them. Sinus tachycardia, basically again the emphasis, basically the electrical activity is originating in the sinus node. The rate is greater than 100 per minute. Atrial and ventricular rates are the same. There's a P wave for each QRS, a QRS for each P wave. The P waves are upright, normal sides. Again, the configuration is good. There's a 1-to-1 ratio as we look at it. Sinus tachycardia, it can be just the body's normal response to exercise. If I got up and walked up a couple of 3 flights of stairs, if I went from the first floor to the 3rd floor in the nursing building, I'd probably have sinus tachycardia. But typically most patients don't have any type of problems with sinus tachycardia. Basically, it can be a normal response to increased oxygen demands of the heart or the rest of the body. It can be caused by fever, stress, pain, dehydration, caffeine, nicotine, alcohol, hyperthyroidism, medications such as adrenergics, anticholinergics. Some of the antiarrhythmic drugs can cause it. Digitoxicity may actually cause tachycardia. You may see it in the acute MI, maybe the first sign of the patient's going into congestive heart failure. So treatment basically is going to depend on your patient. If your patient's stable, you're going to look at the underlying cause and try to treat the underlying cause. If it's pain, give them pain medications. If they have a fever, give them an antipyretic medication as part of that process. Next strip looking at is called sinus arrhythmia. I mean, you can obviously look at that rhythm and see that that basically is an irregular rhythm. You can see there is basically distances from here to here are different from the distances here to here. So this is an irregular rhythm. But if you actually looked and checked your PR intervals are exactly the same as you go through this whole process. They have not changed any. This is usually a variation with respiration, and you'll see this more with patients who are in the ICUs and are on a ventilator because we're increasing their tidal volume and we're totally in control of their ventilations, increasing the pressure, increasing the tidal volumes. This may be something that you see. I'm really not going to ask you to identify a strip like this on the exam, although you may see it. Well, I won't say that. I could use that because the etiology might be a good thing. Understanding that you had a patient that's on a ventilator might causing that, and that's a normal type process that you see. You could also see that on the HESI exam. But again, sinus arrhythmia. Again, etiology is typically respiratory. Treatment, really no big treatment for that. Just monitor that patient and kind of continue to watch and see what's going on with them, with those patients. Oops, sorry, went too far. Sinus arrest, sinus exit block. The main thing you need to know about these, that basically for some reason the SA node basically quits working. Whether there's a problem, whether it's being blocked at the AV node, or basically the SA node has totally quit. These you just need to know, hey, this is a precursor to something else going wrong. You need to be observing this patient closely. If this continues to occur on a patient, you need to notify the healthcare provider because this patient may need to be looking at a pacemaker or something down the road for those. Let's talk about atrial dysrhythmias next. When we look, if you remember the electrical system of the heart, the SA node is kind of the leading pacemaker of the heart. It basically is what paces the heart, starts the electrical activity in the heart, and keeps the rhythm regular. Now, if you remember, this goes from SA node out through the atrial pathways down to the AV node. AV node then slows the conduction to allow the atrium to contract, to push blood into the ventricles, so you're getting that atrial kick with those. From the atrium, from those it goes into the ventricles to the bundle of His into the Purkinje fibers. You can have within the atrial tissue itself electrical foci, or basically small areas of electrical firing that can take over as the pacemaker of the heart, especially if it's firing faster than the SA node or is firing sooner than the SA node. So as we look at these, typically with our atrial dysrhythmias, they have taken over and firing faster than what the SA node is firing, or they're firing quicker than the SA node would fire. That's kind of what happens with a premature atrial contraction, or a PAC. Our sinus, our SA node is firing. We see our P waves. We have normal P waves, and then all of a sudden we've got a beat that comes early. If you're marching this out with your paper, you'll see that this distance here is less than this distances. Okay, so this means this has come early. If you look at this P wave compared to the other P waves, it's different. You notice that this one's what's called biphasic. It goes up, and then down below the baseline, and then back up to the baseline. So this one is early. Okay, again, a PAC comes from the electrical stimulus, comes somewhere from in the atrial tissue itself. Okay, the basic rate on these patients can be bradycardic, normal, or tachycardic. It's just you have an extra firing somewhere in the atrium, and it causes that beat to come early in these patients. Typically, PACs are not a problem for patients. All of us probably have PACs. A lot of times it's caused by caffeine. As we look at the etiology, can be caused by caffeine, can be caused by nicotine, excessive alcohol usage. We'll see in patients with coronary artery disease, valvular heart disease, ischemic heart disease, respiratory failure, hypoxia, COPD. Can see it with medications such as digoxin. Cold remedies, especially Sudafed, pseudoephedrine, can cause those type of things. Can see it with stress, fatigue, overheating. All of those can cause PACs in patients. Unless the patient is having a large number of them, again, it's not really a problem. If they're having some, then we'll go back and we'll see, can we eliminate the caffeine? Can we eliminate the nicotine? Can we see what the etiology is and go from there? If you look at this one, again, the beat comes early. The P waves are not much different when you look at them, but the beat is early, and because it does have a P wave in front of it, it's called a premature atrial contraction. Atrial flutter is one of those rhythms that you will see occasionally. You won't see it as frequently as you will atrial fibrillation, but it is a rhythm that can cause problems for the patient. Atrial fibrillation, when we look at it, basically the atrial rate is between 250 and 350 beats per minute. The ventricular rate is going to depend on the degree of AV block. Remember that AV node basically is kind of the protector of the ventricles. If the SA node is firing way too fast, it's going to block part of those going through. It's kind of the gatekeeper so that the ventricles can function properly. If those ventricles are firing too fast, there's not time for them to fill with blood, and you will decrease your cardiac output. You're also going to increase your cardiac demand on these patients. The hallmark characteristic of atrial flutter is what's called the sawtooth pattern. The sawtooth pattern. If you look at the P waves, it kind of looks like the teeth of a saw, like a hand saw that you're sawing wood with. Okay, so if you look at that, that's kind of what you're seeing. Now, as we see these, basically we're going to have, they are called flutter waves. So let's go over to this one. Here's a flutter wave, a flutter wave, a flutter wave, a flutter wave. Flutter, wave, flutter wave, flutter wave, flutter wave. They're consistent in this strip, okay? So if we counted them, there's 1, 2, 3, 4 before the QRS, 1, 2, 3, 4 before this QRS, 1, 2, 3, 4 before this QRS. That's basically a 4 to 1 block. Okay, it can vary. It can be 1 to 1, which is what you don't want because that means the AV node's not blocking, and then you're going to get into a hemodynamically unstable patient. It can be 2 to 1, 3 to 1, or it can be variable. You might have, in this one, you might have 2. In this one, you might have 4. Over here, you might have 5. Again, you might have 3. So it's variable depending on how the block goes through. It's hard to say what you're going to see, but those are some of the things that you may see with atrial flutter. Again, that comparison, as we look at the sawtooth comparison, these are the teeth of just a normal old-fashioned handsaw for cutting wood. And you can see if you flip that upside down how that looks very much like these problems. So what causes atrial flutter? What causes atrial flutter? Basically, it's kind of rare that it occurs outside the absence of organic heart disease. So typically these patients have some type of heart disease going on. It can be acute or chronic cardiac disease. You may see it as a transient complication of an inferior wall MI. You may see it with patients who have mitral or tricuspid valve disease. You may see it in patients with pulmonary edema, pulmonary embolism or cor pulmonale. Can be with an infection within the heart, whether it's an intracardiac infective processes or a pericarditis type things. You can see it with digitoxicity, hyperthyroidism, alcoholism. All of those can be part of the things. So what are we going to do for these patients? Basically, we're going to give them oxygen, make sure they're on a monitor. Physicians may come in and try to break that atrial rhythm, especially if the rhythm is very fast. If the ventricular rhythm is fast, we've got to slow that ventricular rhythm. So they may try carotid massage on these patients, may give medications such as cardiazem, amiodarone to actually slow this down. If the patient just went into it, we were sat there watching the monitor and the patient just went into it. A lot of times, and they're unstable, they'll do a cardioversion of these patients. If a pacemaker is there and in place, such as a transvenous pacer or pacing wires after cardiac surgery, they'll do overdrive pacing with those. If this is a continual problem, these patients may have to go to the cath lab and receive an ablation to try to stop that pathway that's going on. The one you're going to see more often is called atrial fibrillation. Atrial fibrillation. When we define atrial fibrillation, it's defined as numerous unorganized ectopic foci in the atrial discharging impulses at the rate of 400 to 500 beats per minute. It's causing the atrium basically to quiver instead of contracting regularly. The ventricles respond only to the impulses that pass through the AV node. Again, the AV node is trying to protect the ventricles and keep that rate down so the patient can have good cardiac output. What we see with patients, though, as many times as with the atrial fibrillation, is that we see rates up greater than 100. If you see a rate greater than 100, you may hear the physicians or the nursing staff talk about atrial fibrillation with RVR. RVR just stands for rapid ventricular response. I'll say that again. RVR, rapid ventricular response. So what's happening is the AV node is not blocking enough impulses from coming through, so we're having a very rapid ventricular response on these patients. And for most of these patients, this can be bad because this is typically seen in our elderly population, patients with heart disease and valve disorders. So this can push patients over the edge into congestive heart failure, and MI. Those type things can cause that. One of the things that you will notice about atrial fibrillation, and it's the hallmark of atrial fibrillation, is it is an irregular rhythm. There is no pattern to the QRSs. There's no logic to which impulse gets through that AV node to initiate a ventricular contraction or a QRS complex. You never know which one's going to go through. You may see it long distances like this one. It may be even shorter distances like this one. Or you may see a couple of short ones and then a long one. It's very irregular as you kind of look at that for those. So what is the etiology? This is just another one. This one's got a little bit more coarse fibrillation in the atrium, where this one's got a little bit finer. Now, if you looked at this one, basically 1, 2, 3, 4, 5, not quite 6 there, but if you counted 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. The rate on this one's about 120 beats per minute. Okay, so that's a little fast, especially if someone already has cardiac disease. So rate control is going to be a big issue for this patient. Etiology, typically, again, we talked about more frequent in elderly populations, and we see it as patients get older. Typically more frequent in females than males. Can be caused by rheumatic heart disease, can be caused by cardiac valve disorders, especially mitral stenosis, hypertensive cardiovascular disease, cardiomyopathies, constrictive pericarditis, someone who's had an MI, can be caused by coronary artery disease, COPD, CHF, hyperthyroidism, hypoxia. All of those can basically cause atrial fibrillation. There are patients that will go in and out of atrial fibrillation, and that's usually a problem. When we look at treating atrial fibrillation, basically what we're going to look at is we're going to look at conversion back to a sinus rhythm or rate control with these patients. Complications of atrial fibrillation, number one is the loss of atrial kick. That atrial kick, the contraction of the atrium, adds about 10 to 15% of stroke volume or blood to the ventricles. So if we lose that atrial kick, we're losing about 10 to 15% of our cardiac output. The other problem is that increased ventricular rate. If the AV node is not doing its job, then it's not blocking those coming through. We've got a very fast ventricular rate, which can increase the risk of problems for these patients. Thrombi, because again the atrium is just fibrillating, sitting there just bouncing around like a bowl of jello. Thrombi can form within the atrium, and if we get thrombi and the atrium actually contracts one time, you can push that thrombi through and then actually cause a stroke on these patients. So those are all complications of those patients. Again, with the treatment's going to be looking at rate control and also conversion. Now, when we look at conversion, conversion can be either pharmacologic or it can be electric. Okay, elective cardioversion is something that we will do with atrial fibrillation, and we'll talk a little bit about that. Let's talk a little bit about pharmacology related to atrial fibrillation. When we're talking conversion pharmacology, we're talking about drugs to actually slow down the heart rate and try to convert it back. Drug of choice most of the time now is cardiazem. Amiodarone has been used in the past, but there have been problems with amiodarone maintaining these patients, and PO amiodarone with problems with patients taking it home. So cardiazem is the drug of choice. Most of the time these patients are going to be put on a cardiazem drip in the hospital. If it does convert them, they will be sent home on cardiazem PO and try to maintain that conversion. Cardiazem can also be used for rate control. If a patient is having problems with rapid ventricular response, the cardiazem will actually work not only as conversion but also as rate control for these patients. Other drugs that might be used for rate control could be beta blockers or could be digoxin for these patients. But cardiazem tends to be a very good for this type of process. Now, prevention of complications is a big problem. We talked about that one of the big problems is the blood clots forming within those atrial processes. So we want to prevent any kind of blood clots from forming. So medications to prevent blood clots are going to be given to these patients. The physicians have to basically weigh the risks versus the benefits for these patients, because all these products, Coumadin, Pradaxa, Xarelto, are all basically going to increase the risk of bleeding for patients. And we talked about a lot of our patients that have atrial fib are our older patients. So you've got to weigh that risk of a stroke versus the risk of a fall and bleeding from that. So as we look at those, that's one of our big issues. Now, Coumadin has been used for treatment of atrial fibrillation for many, many years. Coumadin has some good aspects to it in treating. Coumadin does a great job. It can also be used if the patient has had atrial fibrillations related to cardiac surgery and a valve replacement, so it works very well for that. Coumadin can be reversed with vitamin K very quickly if there's a bleed. And Coumadin's cheap. I mean, basically, I can get a 90-day supply of Coumadin at my pharmacy for $10. And so that's pretty cheap. The drawbacks to Coumadin basically are that there have to be monitoring. These patients tend to have monitoring at least every 4 to 6 weeks. Okay, 6 weeks is about the maximum I've seen most patients go without a blood being drawn. The other issue with Coumadin is the dietary that goes along with it. You cannot eat anything with vitamin K, and that typically includes, that is mainly green leafy vegetables. And it's very hard for patients to give up a lot of those. That's your salads, your lettuce, those type of things. And these patients tend not to want to give up those. So trying to monitor these patients and keep them within the therapeutic limit. Typically when we're looking at atrial fibrillation, we're trying to keep the INR between 2 and 3 on these patients. So it can be a little difficult sometimes in getting these patients in and out to get their blood drawn, calling them back, and helping them adjust their dosages. Now, Pradaxa and Xarelto are new drugs that are on the market for treatment of atrial fibrillation. Both are very expensive drugs. Pradaxa, anywhere from $120 to $160 a month. Pradaxa also has to be given twice a day. And Pradaxa and Xarelto have no antidote. There's no way to reverse them. So if someone develops a bleed, you really have a problem at that point in time. You can give enough fresh frozen plasma to finally get rid of them, but it is very difficult if someone has a bad bleed with those. Again, the good part is there's no monitoring, there's no dietary restrictions. Patients tend to like them as long as they're doing well, but again, you've got to weigh the risks versus the benefits. What do I want you to know about these medications? Coumadin, the dietary issues, the INRs, monitoring, and then how you're going to go from a heparin to a Coumadin type process. What kind of teaching you're going to give the patient as they leave on that. Same thing with the Pradaxa, the Xarelto. What is your patient teaching going to be on these medications? What kind of side effects should they look for? What are you going to teach your patients about on these medications? Are there any drug-to-drug interactions, any food-to-drug interactions with these medications? We've already talked about that with Coumadin. Now, when we talked about treatment of atrial fibrillation, we talked about basic conversion. We talked about conversion with medications. The other thing to do with conversion of these patients is what's called electrical cardioversion. Electrical cardioversion is basically a synchronized cardioversion where we use electrical energy, typically no more than 120 joules, to convert the rhythm basically from the atrial fibrillation back to a sinus rhythm. These patients are typically taken to a special procedure room. A transesophageal echocardiogram is completed on these patients. Basically, we're looking at the backside of the heart where we can see the atrium much better. We can see if there's any clots formed in there. They can do a bubble test to kind of see where the pooling of blood is, to see if there's clots there. So those are typically done before that. If there are no clots seen, then basically they will shock this patient and try to shock them back into a normal rhythm. With electrocardioversion, it's different from defibrillation. Electrocardioversion has to synchronize, and that's what these these marks are, basically it's the machine synchronizing on the R wave of the QRS. R wave is the first upward motion of the QRS. And what will happen, you may push the button here, but it's not going to fire until that R wave comes along. So there's usually a slight delay in when you push the button and this patient it fires. One of the things I always have to make sure when you're doing that the sync button is on, and we'll talk about some of this as far as some of the simulations and those type things when we look at that. But basically, this is electrocardioversion. Patients are typically sedated because this is painful. They will jump up off the bed when that's done, so it is quite uncomfortable for the patients. Is it successful? Yes. Sometimes you'll shock them, get them back to the floor, and unfortunately they'll go back into the atrial fibrillation. It's hard. I don't know the percentages of success. I apologize, but you do see these being very successful for our younger patients. Unfortunately, sometimes it's unsuccessful, and we have to look at different types of treatments for these patients. We can't control having trouble controlling the rate with the medications. The patients can't tolerate those medications to control the rates, and we can't basically we can't get them cardioverted back over to a sinus rhythm. If we're having those issues, then these patients will go for an EPS study and an attempt to ablate or basically burn the pathway that's causing these problems. There's two types of ablations. There's basically radio frequency, which is what's been used for several years. They map out to see where the impulses are coming from and then use radio frequency to burn that area. New technology is using actually freezing of those areas to make the scar tissue and stop that electrical activity from coming across that scar tissue. I did post a video on the newer electrophysiology and freezing type process with these patients. These patients basically are going to be treated pre-op, post-op, like your other patients who are going for a PCI, because they go through with a cardiac catheterization type device, so you'll be treating them that way as well. The other thing that they will do with ablation is sometimes if they can't identify the area and there's problems with rate control, is they will actually go in and actually burn the connection between the SA node and the AV node, or actually the AV node itself. When that happens, basically then what you have is you have the heart being controlled by the rate in the ventricles, which, if you remember correctly, is only about 20 to 40 beats per minute. Those patients typically require a permanent pacemaker as part of their treatment. So they'll do the ablation and then go in and put in a permanent pacemaker in these patients. This is just a brief look at the management strategies for atrial fibrillation. If there's no or minimal heart disease, then we'll try to do rate control and rhythm control, beta blockers, calcium channel blockers, digoxin for rate control, AV node ablation, and pacemaker implantation for that. Rhythm control, they've put several up there, but again, what I'm seeing more on the units is the calcium channel blockers, the cardiazem working well. You can see some of these being used for that, but not seen as much. The amiodarone being used for rhythm control. Patients are having a lot of problems taking that at home, so we're seeing some of those. Catheter ablation, again, is part of the rhythm control, trying to see if we can stop that area that's causing the ectopic foci. Kind of looking if they're heart failure, what we're doing. Not a whole lot different from what you're looking at with those patients. We're going to move into kind of a new category. Basically, we're looking at atrial tachycardia. We're looking at multifocal atrial tachycardia and supraventricular tachycardia. You can see by looking at all these strips, these are very fast rhythms. Typically what we're looking at a rate greater than 160 beats per minute. And if you look at these, what we're seeing is all the QRS complexes, they're calling it a narrow complex tachycardia. I don't expect you to be able to tell me whether it's supraventricular, whether it's atrial, whether it's multifocal atrial tachycardia. because physicians still argue about that. We're going to treat this like ACLS treats it, like a narrow complex tachycardia. If you've got a rate of, we're going to count this one, it's right on the line, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, that should be where it is right there. If you've got a rate of 200 beats per minute, then you know your patient is probably in distress at that point in time. So what we want to do is, I really don't care whether you tell me it's a supraventricular or an atrial tachycardia. I need you to know that this is something that needs to be taken care of right away with these patients. Now, when we look at the etiology of narrow complex tachycardia, what we're seeing is basically it's a very rapid heartbeat caused by an AV nodal reentry mechanism. A lot of times it'll begin suddenly and then it'll go away as quickly as it began. In some people, though, it will last a long time and they will come in complaining of shortness of breath, palpitations, fatigue. These can convert over into a complete heart block, causing problems for the patients. Typically, we'll see this with the patients who are in physical or psychological stress, hypoxia, hypokalemia, excessive use of caffeine or other stimulants. May see this with people who are abusing marijuana. Primarily, may see it in patients with congenital heart disease, cardiomyopathies, digoxin toxicity can be some of those type things that we'll do. Treatment is going to be based on whether this patient is stable or unstable. And that's where we're going to try to draw the line. Unstable basically means they're hypotensive, have acutely altered mental status, there's signs of shock, they're having chest pain, or they're going into heart failure. Those would be the unstable patients. Those patients go directly to synchronized cardioversion. If you remember, I showed you a strip a little bit earlier looking at synchronized cardioversion. That strip actually was of supraventricular tachycardia versus AFib, but that's one of the things. Now, if this patient basically is stable, okay, and they're doing okay, then we go to another process. But typically when these patients come in, your responsibility is get them back to a room, get them laying down, get them hooked up to a cardiac monitor, get their vital signs, and get some oxygen started on them. You're probably going to go ahead and draw some blood, going to draw Chem7 metabolic profile on these patients. You're going to put them on a pulse ox and get the crash cart right there close by just in case something goes wrong. If they're stable, then we're going to use that defibrillator and set it on synchronized cardioversion, and we're going to cardiovert that patient. If they're stable, then we're going to try some other maneuvers to try to help that patient break that rhythm. Okay. First thing we're going to do is basically we're going to try vagal maneuvers. Vagal maneuvers basically is having that patient take a deep breath, hold the breath, bear down like they're trying to have a bowel movement. If that doesn't work, the physician will sometimes try carotid massage on these. Again, hear me, I said the physician. This is not a nursing procedure to do carotid massage. That is a physician or advanced health provider doing that. If the vagal maneuvers don't work, then the drug of choice is adenosine or adenocard. Adenosine is a very short-acting drug that basically, when given to that patient, will actually totally reset the electrical activity of the heart. Adenosine should be given at the closest port to the patient, and this is the one medication that we're going to tell you give fast. You're going to give this medication as fast as you can, and then you're going to follow it with 20 milliliters of normal saline. Okay, so dosage of this is 6 milligrams. If you don't get results after the 6 milligrams in 5 minutes, you can go ahead and do 12 milligrams. You can give another 12 milligrams 5 minutes later, but most physicians will stop if it's not successful after the 12 milligrams and move over to other issues. Again, beta blockers can be used, calcium channel blockers can be used, but typically these patients are going to convert with adenosine. Your role basically in giving the adenosine is making sure you have the crash cart available. You're the one that's going to be giving the medication, making sure you're giving it at the nearest port, you're giving it fast, and you're flushing it with 20 milliliters of saline afterwards. You're also there to support the patient. You need to let them know You may feel funny when we give you this medication because their heart's going to stop in most cases or slow down very slow. So you need to be there and support them as that. Always make sure you've got that crash cart at the bedside as you're doing this. A lot of rooms will have monitors in there, but the crash cart's not in there. Pull that crash cart into the room. Make sure it's there in case something happens with this patient. So you're going to continually monitor that patient. Now the half-life of this drug is very, very short. It may be... it lasts 2 to 5 minutes, so it may not last long. So you just have to monitor that patient after that is going on with those patients. All right. Again, supraventricular tachycardia. I do not want you being able to tell me the difference between SVT and atrial tachycardia. We're going to treat them both the same way, and what I want you looking at is the medication Adenocard. And making sure you understand how to give it, make sure you understand synchronized cardioversion, and make sure you understand the care of this patient as we provide these services to them. Let's look at junctional rhythms. Not going to spend a lot of time on junctional rhythms. Junctional rhythms basically are rhythms that are generated by and around the AV node. When the SA node fails, then something takes over, and of course we know that the AV node is what typically will take over. When you look at a rhythm strip with a junctional, typically what you're going to see is no PR interval or no P wave. You can see you have your regular QRS, but there are no P waves here. Remember, the normal rate for the AV node is 40 to 60. So we're looking 1, 2, 3, 4, 5. So we got a rate of about 60 on this patient. But you see there are no P waves with this rhythm. So if you see a rhythm like this with no P waves, a normal QRS, and a rate somewhere between 40 and 60 per minute, that typically indicates a junctional rhythm. Now, with junctional rhythms, you can also see an inverted P wave. In other words, that P wave may be out here and be upside down when you look at it. That's one of the things you can also see with a junctional rhythm. Occasionally with a junctional rhythm, you'll see the P wave coming in back here on the back side of the QRS, maybe before the T wave. That happens occasionally. You can see that. But the main thing with junctional rhythms, understand it's telling you that something is going wrong with the SA node. It may be temporary, it may be permanent, but you need to monitor these patients carefully to make sure that they don't go into a slower bradycardic rhythm or go into a complete heart block type issue with these patients. So very important if they're in a junctional rhythm, if they change from a sinus rhythm to a junctional rhythm, to let the provider know that the patient has converted into a junctional rhythm. Things that can basically cause a junctional rhythm. Sorry, I got to turn pages here. Things that can cause a junctional rhythm can be an MI where the SA node is wiped out, especially inferior MIs. Some type of dysfunction of the SA node can be seen with digoxin toxicity, with acute rheumatic fever, and may occur after open heart surgery, especially if we're looking at valve surgeries. Again, a lot of times with those type surgeries, it may come back, but again, you've got to observe and what's going on. The big thing is that it serves as to let you know that something is wrong with this patient. You may see some loss of cardiac output because of the slower rate and the lack of atrial contraction on these patients. Main thing is you've got to find out why is this rhythm happen, what's going on, and treat your patient. If they're bradycardic and there's signs and symptoms of cardiac instability, then you've got to get the rate up on these patients. I'm not going to talk a whole lot about accelerated junctional. You can see on this particular one, see how the P waves are inverted on this one. So we do have P waves. Now you can have what's called an accelerated junctional rhythm. We would know this was junctional because our P waves are biphasic, are actually inverted at this point in time. Their recent catecholamines, exercise, or whatever has caused this rate to jump up more than that 60 beats per minute as we see that. Not going to really test you on that, just need to be aware of that term. Here are the big ones. when we start talking about ventricular dysrhythmias. Okay, these are the ones that you've got to be very concerned about. These are the ones that are going to kill your patient. Okay, as we look at this, we're going to start out talking about premature ventricular contractions. Premature ventricular contractions. Premature ventricular contractions are an ectopic beat originating somewhere low in the ventricles, usually below the bundle of His, due to irritability of the ventricular cells. They can be occasional, they can be frequent. Frequent is considered anything greater than 6 per minute. They can be regular, such as every other beat, which is called bigeminy, every third beat, which is called trigeminy. You can have two PVCs together, which is called a couplet. You can have 3 together, which is called a triplet. Anything more than 3 together is called ventricular tachycardia. PVCs can be unifocal or multifocal. Now, when I talk about unifocal, I mean they're coming from the same location. If you look at this PVC and this PVC, you can see they look the same. They're basically coming from the same area. Now, characteristics of the PVC is basically they're a wide, bizarre-looking complex. They fall early in the cardiac cycle, so you would actually expected the next beat to have fallen right about here. Instead, you've got this beat coming early. You have what's called a compensatory pause afterwards, so this beat doesn't just come in just like it would. It waits to the next time it should fire and fires when it should. Okay, the PVCs tend to increase as we get older. You may see it with myocardial ischemia. You can see it with low magnesium. You can see it with acidosis, stress, excessive nicotine and caffeine use. You can see it with anesthesia. You can also see this as part of reperfusion therapy. If you remember when we talked about coronary artery disease, our whole goal is to get these patients in and get that myocardium reperfused. As we get that myocardium reperfused, because of the metabolic processes that are going on there, there's things released that's causing irritability of that wall. So you may see PVCs, and that's usually a good thing after reperfusion. It lets us know that the blood flow is returning to those areas. But if we're taking care of a patient that's had an MI, has had cardiac surgery, we are concerned when we see PVCs. Okay, typically, again, if they're infrequent, we don't worry about them. Most patients will not know that they're having PVCs unless there are several in a row or they're regular type processes. If you're listening to the patient's heart, you're probably not going to hear that beat. It's going to sound like a skip beat. Same thing if you're checking the pulse. You're not going to feel that as you check the pulse on these patients. The biggest concerns, these can be precursors to ventricular tachycardia. So we need to make sure we're noting if patients are having PVCs, how frequent they're having the PVCs, and what they look like. Now, what we had before are unifocal PVCs. What we have here is called multifocal PVCs. One thing about a PVC, the QRS complex, whether it's going down or whether it's going up, is always in the opposite direction of the T wave. So we've got the QRS complex on this one. It truly is a QRS complex because the first downward deflection is a Q. Or in this one where really our first deflection is up, it's still called a QRS complex, but the T wave is here going in the opposite direction. So a wide, bizarre looking beat, and where the QRS is going the opposite direction of the T wave is what we see with a PVC. I'm more concerned about this patient because these are coming from different areas. They're coming from a different electrical foci within those ventricles. So there's more irritability in the ventricles, which makes it much more unstable for the patient. So I'm more concerned because I have these. Now, if I'm seeing more than 6 per second of PVCs, typically in critical care units, you have the standing orders to go ahead and start treatment with these patients. Same thing if you're seeing like triplets, which is 3 PVCs in a row or more than that, you have orders to go ahead and start. Drug of choice typically is amiodarone, 150 milligrams IV push, and then starting a drip with that. Remember with the amiodarone drips, you have to run it through a filter. It has to be run through a filter as part of that process when you're giving those. Other drugs you may see is called lidocaine. Lidocaine is a drug that's been around for a long time, and some physicians still like lidocaine because they're comfortable with it and have used it for many years. If a patient's having a lot of PVCs, main thing you want to do is you want to check, make sure they're oxygenating well, look at what their O2 sats are. Take a look at their electrolyte levels. What is their potassium? And specifically, what is their magnesium levels? Low magnesium levels can lead to these type of beats. Now, you see here we had 3 in a row on this patient. I lost my cursor, sorry. There it is. So 3 in a row on this patient. So that's a problem when we start seeing that many in a row. And then we see another one here. And if you look at that, it almost looks like on this one there's probably another one right behind that one. So what do we do? How do we treat? We've basically talked about it. With the PVCs is basically drug intervention, typically making sure they're oxygenated, making sure that the electrolytes are normal. And if those are all normal, then medications such as amiodarone and lidocaine are the drugs of treatment. Now, I wanted you to, next thing we're going to look at is called ventricular tachycardia. Ventricular tachycardia. Now, as you look at this, it looks like it's just a number of PVCs hooked together. And really, that's what it is. Oh, dear. Why did that happen? Don't know what happened. Sorry about that, guys. But really what this is just a number of PVCs together. There is an electrical stimulus coming somewhere from low down in the ventricles that has basically taken over the electrical system of the heart. Ventricular tachycardia is defined as more than 3 PVCs that occur in succession or in a row at a rate of more than 100 beats per minute. Typically, ventricular tachycardia, the rate's going to be somewhere between 140 and 160 beats per minute. It can be brief or it can be sustained. This is a life-threatening dysrhythmia. This is a life-threatening dysrhythmia. So if you see this on the screen, you must go assess your patient. Go assess your patient. Patients can have a pulse with this. And the treatment's going to be based on whether the patient has a pulse and what their stability is as far as the cardiac goes, as what their blood pressure, their things, and their level of consciousness. Etiology, it's usually from increased automaticity or a reentry mechanism. Typically, it's caused from ischemia, heart disease, MI, cardiomyopathy, hypokalemia, or decreased magnesium levels. You can see this if someone's had an MI and they have a ventricular aneurysm. Drug toxicities can cause these type of problems as well. So what are you going to do for this patient? Let me just, before we get over there, these are 3 different types of ventricular tachycardia. You can see they all look different. This is a unifocal. This is more multifocal. There you have several foci that's firing. This probably looks more like ventricular fibrillation, but because they're large and wide, is probably ventricular tachycardia. My guesses are with this patient, they do not have a pulse, so you're going to treat the same thing as you would ventricular fibrillation. Ventricular fibrillation, you're going to fibrillate this patient. This one is called Toussaint de Pointes. This one is typically caused by a low magnesium level, and typically medications are not going to do any good. You've got to get the magnesium level up on these patients for them to do better. Typically what we're going to do with most of the time with ventricular tachycardia is we're going to defibrillate this patient. If they have no pulse, start CPR, call a code. Once the crash cart arrives, you're going to hook them up to the defibrillator, and you're going to go ahead and shock that patient. The amount of energy you use is going to depend on whether you're using a monophasic or a biphasic defibrillator. And I'm not going to try to get into that a lot this semester. That comes as Ms. Lee talks about ACLS more next semester. But typically, if it's a biphasic, you're going to go with 200 joules. If it's a monophasic, you're basically going to start at 360 joules and shock them there. Typically, you're going to do CPR, and give them epinephrine 1 milligram IV push, and then repeat that every 3 to 5 minutes with these patients. So CPR and electrical. The quicker you can actually get the electrical activity, the defibrillation, the greater a chance these patients have surviving. When we talked about prevalence of MIs, that many patients never make it to the hospital when they have an MI, and that a large number of patients never realize they have coronary artery disease till they have an MI. Well, typically the rhythm that they will have when they basically are out in the field and when they basically go down outside the hospital is ventricular fibrillation. Ventricular fibrillation. Again, this is a deadly or lethal arrhythmia. Basically what's happening, there is no organized contraction of the ventricles, no organized electrical activity. The ventricles are sitting there fibrillating, so there is no cardiac output going on. What needs to happen is a total reset of the electrical activity of the heart, and that's done through defibrillation. Whether it's through a defibrillator or an AED, the sooner that we can get the defibrillation done on this patient, the greater the chance we have of saving this patient. Typically, it's caused, just like we talked about with ventricular fibrillation, it's electrical chaos. It may be the first sign of coronary artery disease. It can be from an acute MI. It can be from a PVC that fires on the T wave or the one before it. That's why we talked about some of the medications increase the QT interval. Can be caused from low magnesium. Can be caused from hypokalemia. All of those things can be. But basically, when this patient, if you see this, you've got to establish the unresponsiveness, call for a code, start CPR, and as soon as the crash cart gets there, provide electrical treatment for that patient. Again, this is a lethal dysrhythmia. When you look at that, that's coarse VFib, and this is fine VFib. The finer the VFib, the less likely the patient's going to be able to survive. So you really must make sure getting that electrical shock as quickly as possible. We're going to move into AV blocks. Again, this semester, AV blocks, the only AV block you're going to be tested on the unit test is the first degree AV block. But you may see second degree and third degree AV blocks as part of the HESI exam. Remember the conduction system. I'm not going to go through it a lot, but you've got the SA node up here, which is kind of the on-field quarterback. It goes down through the internodal pathways, down to the AV node and across to the other atrium. When you get to the AV node, the rate is beginning to slow down. It then goes down through the bundle of His, down through the through the bundle of His to the Purkinje fibers, to the right and left bundle branches, and then out into the Purkinje fibers out into these areas. So what we're looking at is if this fails, then this is going to take over. If this fails, then these are going to take over as the pacemaker of the heart. First degree AV block. First degree AV block is basically where you have a PR interval that's greater than 0.20 seconds. If we look at this PR interval, we're going to go where the PR interval starts, and we're going to go to the beginning of the QRS. If we look at this PR interval, we're looking at about 1, 2, 3, 4, 5, 6, 7, 8, 9, somewhere between 9 and 10 small blocks. So basically somewhere between 0.36 and 0.40 seconds on that block. With a first degree AV block, there is a P wave for each QRS. There's a QRS for each P wave. It's just that PR interval is elongated. Now as you go through the strip, the PR interval from here to here to here to here to here is going to be constant. So it's going to be about that 0.36 to 0.40 seconds as you go through that rhythm strip. Okay, it can be bradycardic, it can be tachycardic, it can be within 60 to 100 beats per minute. It really doesn't matter. First degree AV block is determined by a PR interval greater than 0.20 seconds. PR interval greater than 0.20 seconds. Many times this is a transient type process that's going on after an MI or after a cardiac surgery. It's really defined as a conduction delay, not really a true block. It can be caused from ischemia, rheumatic fever, hyperthyroidism, drugs such as digoxin, flicicide, and IV verapamil can cause these. Typically, this patient is asymptomatic, and all you really need to do to this patient is continue to observe them. If it's associated with bradycardia and they're symptomatic from the bradycardia, you go ahead and give them some oxygen and follow the treatment protocol for bradycardia for this patient. Second-degree block is broken down into two types of blocks. It's broken down into Mobitz type 1 and Mobitz type 2. I will post for you a cute little video on Winky Bach or Mobitz type 1 that maybe make you feel understand a little bit better. But if we look at this rhythm strip, as you look at it, go back and remember your basics. Count your number of P. Look at your rate. Okay, so we've got 1, 2. We've got a 6-second strip going from here to here. So we've got 1, 2, 3, 4, 5. We've got a ventricular rate of 50. Okay, let's count the atrial rate. 1, 2, 3, 4, 5, 6, 7, 8. So our atrial rate is greater than our ventricular rate. Now, if we looked at, we're going to start with this group of complexes here. Here's our P wave. Here's our PR interval. Here's our P wave. Here's our PR interval. Here's our P wave, our PR interval. Then here's our P wave. Notice something missing? There's not a QRS complex here. When you look at Winky Bach, Mobitz type 1, your PR interval goes from shorter to longer to longer till you finally drop a beat. Now, it's not necessarily 3 beats. It may be 4, it may be 5, it may be 2. But the hallmark of a Mobitz type 2 is an irregular ventricular rhythm. If you marched out the atrial rhythm is actually going to be regular. So with Mobitz type 1, ventricular rhythm irregular, atrial rhythm regular. Okay. Increasing PR interval until a QRS is dropped. So a Winky Bach or a Mobitz type 2 is basically a loss of a QRS complex. So basically the PR interval lengthens until a QRS complex is dropped. Etiology of a Mobitz type 1 typically can be from an inferior wall MI, ischemia to that type area, digoxin toxicity, rheumatic fever. Typically rheumatic fever is transient. Can be from electrolyte imbalance. Typically, once we correct the electrolyte imbalance, it will be fine. And from promecanamide therapy. Significance with Mobitz 1 is typically always transient. Can it advance to a higher level block? It can, but it rarely does. If the patient is asymptomatic, then all we do is monitor to make sure it doesn't progress to a different type of block. So really, especially if a patient, you're working the CCU and a patient's had an inferior wall MI, you may see this, but it just bears more monitoring to make sure that it does not progress into either a second-degree AV block, Mobitz type 2, or to a AV block, a third-degree AV block, complete heart block, as we look at that. So Mobitz type 1, Winky Bach, longer, longer, longer drop. Longer, longer. PR gets longer, longer, longer drop. Longer, longer, longer drop. So you'll see that as you go on. Ventricular rate irregular. Atrial rate regular. So let's look at a second degree AV block, Mobitz type 2. Again, as you look at your strip, look at your ventricular rate. 1, 2, 3, 4, 5. So we've got a ventricular rate of 50. Okay, then let's look at our atrial rate. So we basically have 1, so we've got a P wave, 2, 3, 4, 5, 6, 7, 8, and 9. We may not count that one, but our ventricular rate basically is, if you look, there's probably one right before this, but we don't know. So if we look at our ventricular rate, 1, 2, 3, 4, 5. Look at our atrial rate, 1, 2, 3, 4, 5, 6, 7, 8, 9. Really what we see typically is a 2-to-1 block on these patients. There's 2 P waves for each QRS. If you measured the PR interval on this P wave and this P wave and this P wave, they would be consistent. So the PR interval on the one that's conducted is consistent. What we have are P waves that are not being conducted through the AV node. In other words, the AV node is blocking impulses coming from the SA node. And we don't know about this one, but my guesses are that one is blocked as well. So with a Mobitz type 2, basically you have P waves that are being blocked. Now, you can have basically 3 P waves and then one going through. Okay? It can be a 2-to-1, 3-to-1, 4-to-1 block. It really is what you're looking at. But if you march these out from here to here to here, 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 and here, these are going to be regular. Same thing if you marched out the QRSs. They would be regular from there to there to there to there. They're regular. So your QRS is regular, your P waves are regular. There's just more P waves than there are QRSs. There are P waves that are not being conducted through the system. So typically with Mobitz type 2, you're very concerned with these patients. This can lead to basically to cardiac instability. And these patients typically going to require a pacemaker, whether it be transcutaneous, transvenous, or permanent pacemaker. Typically what we see with these patients is it's from an acute inferior MI or ischemia, severe coronary artery disease. Can also see it with myocarditis. Sometimes these patients are asymptomatic, but typically we're going to see these patients with some sort of symptoms of decreased cardiac output, hypotension, syncope. And again, our rate is 50, our ventricular rate is 50, so we've got bradycardia going on with this patient. Treatment's going to be based on the symptoms of the patient. If the patient's had an acute MI and it's showing a block, the pacemaker is going to be inserted. If there's changes in the cardiac output, again, a pacemaker may be the treatment of choice for this patient. A complete heart block is basically there's absolutely no electrical connectivity. I'm sorry, I had to cough. With a complete heart block, there's absolutely no electrical connectivity between the SA node and the ventricles. Everything is being stopped at the AV node. So the AV node is stopping everything that's going through and is at that point controlling the rate of the heart. So a complete heart block is exactly what it is. There's a complete blockage of the electrical activity coming from the SA node going down to the ventricles. If you look on this strip, you can see that basically we have P waves, and if we march those out, they would be regular because the SA node is firing at a regular rate. If we count them in this strip, we'd have a rate of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. A rate of about 120 beats per minute. And it's probably fast because it is sensing that there's a decreased cardiac output and we need to speed up the rate. If we looked at the ventricular rate, it's also regular. The AV node is firing at its regular normal pace. We see here we have a rate of about 50 beats per minute. The thing is, if we look at the PR intervals, and you can see it here with the PR intervals, they are different lengths. So basically there's no correlation between the P waves and the QRSs. The P waves are going to fall where they normally fall, and the QRSs are going to fall in a regular rhythm. This is one of the hardest rhythms to recognize just on a 6-second strip. Many times it's going to take more than a 6-second strip. It may take a 12-15 second strip to really recognize this one. This one's easy. The P waves are pointed out and the QRS is pointed out. Again, I am not going to have you trying to recognize a third-degree heart block for this unit test. Do understand that for complete heart blocks, the treatment is going to be, if they're bradycardic and it's symptomatic, then we're going to try to bring the rate up with like atropine, epinephrine, dopamine. Ultimate treatment for this patient basically is a pacemaker, whether it be transcutaneous, transvenous, or permanent pacemaker for this patient. Typically we're going to see this type occur with an inferior wall or an anterior wall MI. Severe digitalis toxicity is typically a post-surgical complication of mitral valve replacement. You can see it with hypoxia, you can see it with congenital abnormalities, infections such as rheumatic fever, and any kind of disease that causes problems with the conduction system. Again, the pacemaker is the treatment of choice for this patient. We may need to get some atropine started on this patient, or some dopamine or epinephrine to keep that ventricular rate up until a pacemaker can be inserted on this patient. Okay. Again, another one. If you look, here's a P wave. If you look at this T wave, notice that it's taller than these T waves. You actually have a P wave hidden in here. You have a P wave, a P wave, a P wave, a P wave, another P wave, here, and here. So if you march those out, you would see they're regular. If you look, there's 1, 2, 3, 4, 5, 6, 7, 8, rate of 90 on the atrial. We do the ventricular 1, 2, 3, 4, 5, rate of 50 like the other one. Really what we're seeing is the ventricles firing at their own rate and the atrium firing at their own rate. If you march these out, again, these would be very regular. If you march these out, they're going to be very regular as you look at it. Idioventricular, all I'm really going to say about idioventricular rhythms is basically it is a dying heart. Okay, it really is a heart that's dying. We've done pretty much everything we can for this patient, and that heart is beginning to die. You see how it's widening, the QRS is widening out. There's just almost no electrical, no mechanical activity going on with these patients. Odds are, if you were taking care of this patient, there would be very, very weak pulses. This patient may be apneic, so it could be a problem. But typically, idioventricular, when you're talking about that, you're talking about a dying heart. This just shows it in a different view for these patients. Asystole, of course, everybody knows asystole is the absence of a heartbeat. So with this patient, there is no mechanical or electrical activity going on with his heart. One thing, if you see this going across your monitor, always remember to check your patient. It could be as simple as a lead off, so you want to check your patient. If your patient's unresponsive, begin CPR, call the code, bring the crash cart in. Once you get them hooked up to the crash cart, you need to check that rhythm in 2 leads to make sure it's asystole and not a fine V fib. We do not shock asystole. Again, we do not shock asystole. There is no electrical activity to shock at that point in time. What we need to look for, what is the cause of this asystole? Basically, we're going to continue CPR, give them epinephrine, get them intubated, make sure we're oxygenating, breathing for them, and we're going to go at that point in time with this asystole. Again, 2 leads, making sure it's not fine V fib, CPR, looking for what's going on. Your major response with this patient is identifying it and beginning CPR and getting the code team involved on this patient. I'm just going to briefly talk about pacemakers. Pacemakers we've talked a little bit about with second, third degree. When you see a monitor strip that basically has really tall spikes like this is the pacemaker firing. In this first strip, we have an atrioventricular pacemaker. The pacemaker is firing to stimulate the atrium to get that atrial kick, okay? Then it's firing to initiate the ventricles, doing it both here. Here on this one, we have the atrium pacemaker firing. We get a P wave, and then we just get a normal QRS looking complex. It sensed that the QRS fired, so it doesn't need to pace for the ventricles. Okay, whoops. Then on this one, basically we're seeing just a ventricular pacemaker. We see the firing here. We've got a P wave, but it didn't fire, and so the ventricle pacemaker had to take over and fire for this patient. Just know that pacemakers, when you see them, you see these tall spikes. They can be going down or they can be going up depending on which lead you're looking at. But you see that, that's a pacemaker. That is really all I have on arrhythmias. I know that's enough. I wish you luck. We'll see you at the review. If you have questions, please send me an email. Thank you.